Welcome everybody to Mini Medical School. This is the second week of this session. Couple things quickly. I want to make sure we had some questions last week. There was a couple snafus last week. So this week, the way that we're going to be taking attendance and the way that we're going to be taking attendance from now on is you will get a survey as soon as Dr. McCarthy starts talking. A survey will appear in the chat. Your job is to click on that survey and take it before 9 o'clock tonight. If you do not take it before 9 o'clock tonight, you will not be counted as present for this session, and therefore you will not be eligible for a certificate. If you don't care about getting a certificate, don't worry about the survey. But if you need to have a certificate of attendance, make sure that you click on that survey and you take it before 9 o'clock tonight. There is no need to give me your email. There is no need to tell me your name. Just take the survey. So that's an easy way of getting that done. So that will go on as soon as Dr. McCarthy starts talking. So week 2, welcome back. Today we're going to be discussing bariatric surgery with Dr. Elizabeth McCarthy. And I'm going to turn it over to Tim to introduce her. Tim.
All right. Good evening, everybody. Elizabeth McCarthy, MD, is a bariatric surgeon working for Christiana Care. She graduated from Sidney Kimmel Medical College at Thomas Jefferson University Hospital in 2016 and completed her residency at Christiana Care in 2021. She completed a fellowship at Stony Brook University Medical Center in 2022. Dr. McCarthy is certified by the American Board of Surgery, and she is joined with a special guest tonight, her patient Shellee Chew, who will do her own presentation later on in the evening. Welcome, Dr. McCarthy.
All right, Dr. McCarthy, the floor is yours.
Okay, thank you so much for having me. All right, let me get this screen shared. I'm like the least technically savvy person, so I apologize.
You're doing great.
Doing great.
So thank you so much for that introduction. I'm so happy to be here to be talking about bariatric surgery, which is near and dear to my heart as my chosen specialty after pursuing general surgery residency. So a little bit about me. My name is Liz McCarthy. As was so introduced, one of the bariatric and advanced GI surgeons here at Christiana. My main practice is at Wilmington Hospital, but I do take some just general surgery shifts down at Union Hospital. And today I'll be talking about bariatric surgery and obesity and other diseases associated with this. So again, I was born and raised in Media, Pennsylvania, so not too far from here. I ended up going to Tulane for my undergraduate degree, and I actually majored in theater and French. After that, I decided to pursue medicine, and I ended up doing a post-baccalaureate program at Penn, which really just involved taking basic science classes, which I had not taken in undergrad due to my theater and French major. I was lucky to matriculate at Jefferson for my medical degree, and then ended up matching for general surgery residency here at Christiana Care. I finished my 5 years. During that time, decided that bariatrics was really the direction that I wanted to go in. And I was lucky to match at Stony Brook University Hospital with some wonderful mentors, Aurora Pryor and Dino Spagnolis. And I was really helped out by my greatest mentor, who I now work for, Caitlin Halbert, who Shellee knows very well as her surgeon. So I'm just lucky to be back at Christiana and happy to be here and able to talk to you guys a little bit about bariatric surgery. So what are we going to learn today? What is bariatric surgery? What diseases does it treat? What are the different types of bariatric surgery? Because there are multiple. How does one prepare for bariatric surgery? So it's a tool, it's a step in the process, but it is a lot of preparation, and hopefully Shellee will get to touch on that a little bit after I speak as well. And then what are some important outcomes? So to start off, what is bariatric surgery? So this is surgery of your gastrointestinal tract and it helps to improve obesity and metabolism. And these procedures help us, but also with resolution of other medical problems. So in the media, you may have seen these two folks. Al Roker famously underwent bariatric surgery back in 2002. So he's almost 21, 22 years out now from his surgery. So he's probably one of the first really huge influences on getting knowledge out there about this procedure. And then if any of you are big TLC fans, you may know Dr. Now, who is the physician who operates in My 600-Pound Life. You know, despite what people might think of that show, it is a pretty good insight into like the steps that it really does take a lot of effort to be able to go through bariatric surgery and to do this. So, you know, why bariatric surgery? And really, this comes down to obesity. And obesity is a disease. It's a disease of excess fat accumulation. The most recent statistics actually show that about 42.4% of Americans are obese. And in Delaware, over 1/3 of the population is obese. You know, in our nearby states, Pennsylvania and Maryland, it's about 30%. And then in New Jersey, just over 25%. So, you know, it's really not a small issue. It's an epidemic. And because of the nature of obesity and the disease process and the fact that it is associated with so many other what we call comorbid diseases or disease processes that basically occur because of obesity, it's a really important medical issue that we need to treat. And then, you know, morbid obesity is what we talk about when we're talking about bariatric surgery. And really, this is when someone is about 100 pounds, or at least 100 pounds, like 80 to 100 pounds over their ideal body weight. And that's measured by your body mass index. Body mass index really is sort of a ratio of height to weight to determine the amount of body fat that one has, or a rough estimate. It's not perfect. If someone is super muscular or super tall or very short, you know, things are a little adjustable, but it really generally gives a good idea for the basic population about what kind of excess fat one has. And it's how we determine if somebody meets criteria for bariatric surgery. So if you're curious and you want to take a look, it's very easy to figure out your BMI. You can Google BMI calculator and find one right away. And as I said before, it's important because this is how insurance companies decide if someone qualifies for surgery. It's also important because as you kind of reach a higher BMI, that's when your risk for other medical issues really begins to climb. So when we talk about bariatric surgery, we talk about who qualifies for obesity. So anybody whose BMI is greater than 40 by insurance would automatically, if their insurance covers it, be covered into bariatric surgery. Or if your BMI is greater than 35, but you have one of these general medical problems, diabetes, high blood pressure, and then sleep apnea. Sometimes high cholesterol can also be associated and can also help with coverage, but it's a little bit harder to get coverage there. So what causes obesity? Genetics. Sure, maybe mom and dad are also obese. Eating habits. Yes. I mean, we learn our eating habits also from our community and from our parents. So these things kind of tie together. Our environment, where we grow up, what kind of job we have, how active we are, all of those things still contribute. And then lack of exercise. Again, activity is really important. And this exercise doesn't necessarily have to be, you know, an hour or running a marathon every day. But even little things about, 20 to 30 minutes, 5 times a week of getting outside, walking, getting your heart rate up can really help. But, we talk about all of these components as a part of this because it's not just one thing that affects obesity. And I think all of these things together, we have to figure out a way to move forward and get on with that. So let's take a look at this next slide because it's pretty interesting. So every organ system is affected by obesity. I think, commonly we think about things like diabetes, heart disease that are associated with being overweight or obese. Many of you may know that sleep apnea can be associated with obesity and that weight loss really helps with that. But I would argue that it's not too commonly discussed that obesity can be contributing to gallbladder disease or gynecologic abnormalities or cataracts. Cancer is a big one. You have about a 10 to 41% increase of developing a cancer if you are morbidly obese. And then I think, what's most striking is the findings that it can actually cause early death. So, this is a problem that affects all parts of our body. And I think it's important to know that so that we know that, I think when initially people heard about bariatric surgery, they think, oh, that's just weight loss surgery. Like some people think, oh, it's the easy way out, quote unquote. And I think by the end of the presentation, you'll see that it's not just about weight loss, and it's certainly not the easy way out. And this is really helping people to live better, longer lives. So with that, let's talk a little bit about options for weight loss. So we've all heard, diet, lifestyle, exercise more, eat less. I mean, sure, that works generally in the short term. People have done, intermittent fasting, portion control, on and off Weight Watchers, and you can see some really great results, but those results are very difficult to sustain long term. And then we talk about medications. So there's all sorts of medications out there right now, and I'll get into that a little bit more, I think, on the next slide. Those are also helpful, and you can see good results with them too, but how long can you be on the medication? Does the medication last long term? Can you be on the medication when you have other associated diseases? Sometimes you can't. And this is when, surgery really starts becoming more and more of a viable option for people. So, there's multiple diets we talked about: Herbalife, Jenny Craig, Weight Watchers. Lots of my patients have done, keto or intermittent fasting, and they'll say, oh yeah, when I'm doing keto, I can lose, 20 to 30 pounds, but as soon as I eat that piece of bread again, I'm done. And it's really frustrating because it's not that they're not trying. It's not that we're not trying. It's just difficult to keep long term. So usually people do see some weight loss, but it's about 1 to 2% of their excess weight long term. So, maybe 1 or 2 pounds, maybe up to 5 pounds in some people, but really not a significant chunk of the weight that one needs to lose when they do have morbid obesity. And then medications. So I think these are really, really kind of hot right now. I think Mindy Kaling and Chelsea Handler are talking about Ozempic a lot. And these medications do work, and they're wonderful. They're actually a hormone receptor agonist. So they help with increasing insulin, stopping the liver from making sugar, and then actually delaying stomach emptying so that, you get fuller faster. You don't want to eat. And then all of the hormonal changes also help with weight loss. And people can see really excellent results. Long term, we're looking at about like 15% weight loss, which is good. It's a good amount of weight, but again, it's hard. It's not necessarily, enough to change all of the other hormones that are going on, to change all of the other comorbidities. These medications were actually specifically made to help with diabetes, and they do. But I found that a lot of my patients say, oh yeah, I tried Ozempic and it just didn't work. And then some people try it and they say, it's amazing, but I haven't really found a lot of people that find that like sort of in between. And again, how long-term can you be on these medications? They're still sort of new and we're learning. So definitely more to come as far as how these will kind of go out long-term. And then we should talk about weight loss after surgery. So this looks at expected excess weight loss after 2 years, the first set of numbers there. So you can see with a gastric bypass, we're looking at, anywhere from 62 to 80% of your excess weight. So if we're talking about 100 pounds overweight, we're talking about 62 to 80 pounds that you can lose. With the sleeve, it's just slightly less. And then there's another procedure called the duodenal switch, where again, it's just slightly less, but a little bit of a tighter variable, which is great. And then expected total weight loss after 2 years, again, kind of bypass and switch, definitely a little bit higher, although more variable with the bypass than the switch. And then just slightly lower with the sleeve, but we're looking at a third of somebody's body weight. And that's, at the 2-year mark, which is well after surgery. And I'm hoping that Shellee will be able to talk to you about that a little bit more later as well, because she's, she's about 2.5 years out from surgery. So good information there. And I'm going to come back to this slide later, kind of once we've learned about what these surgeries actually look like. So methods of bariatric surgery, we talk about restrictive methods, malabsorptive methods, and then combination methods. So the gastric band was kind of an early exciting option for people because this was, quote, more minimally invasive. It was reversible. It was an implantable band that goes around the stomach and allows you to eat less. So this is restrictive. The sleeve gastrectomy, we initially felt more restrictive, and that's where we just take a portion of the stomach. And again, I'll go over it a little bit more later. But I have a little bit of a malabsorptive component and definitely has a hormonal component that helps also with weight loss. The gastric bypass, which I think is sort of the most well-known of our bariatric surgeries, where we actually make a small stomach and then rearrange the bowel. So this is a combination. And the duodenal switch, which is most similar to the gastric bypass, but almost like combines a sleeve and a bypass together. And again, is one of those combination procedures. So the gastric band, a restrictive procedure. It was the insertion of this silicone inflatable band. It gets placed around the top part of the stomach to basically create like a small pouch for food to go through, and then make it more difficult for that food to pass down through the stomach in the hopes that, people would eat less. You could fill that band with fluid, making that, that emptying valve, I guess you could call it, smaller or larger, depending on, I now can't, I vomit every time I eat now because it's too tight, versus I feel no restriction. I would really like some more fluid in the band. It has fallen out of favor because of the complications associated with it. These bands can slip, they can erode, they can become infected. There are definitely patients who come in and they still have bands and they get fluid like filled or removed, kind of depending on how they're doing, and they're doing very well. But we've also found that it's not the best option for long-term weight loss either. So our practice is no longer placing them. We're actually converting a lot of them to gastric bypasses. But we are taking the time to, speak with the patient, adjust the band if that's working for them, and have that conversation. Next is the sleeve. And this is where we remove about 80% of the stomach. Getting your stomach from about the size of a football to the size of a banana. Kind of a tubular stomach rather than a big bulky stomach. The exciting part about this procedure is that it actually removes the portion of the stomach that produces a hormone called ghrelin, which we like to call the hunger hormone. And that really can stimulate hunger. In medical school, we always remembered it as like grr, like your stomach makes grr noises, ghrelin. So removing that portion of the stomach actually helps with hunger and reducing hunger. And then also helps with restricting the amount of food that you can fit into your stomach. And people see about 60 to 65% excess weight loss, long term. And so when we're talking about morbid obesity, just as an example, you're 100 pounds overweight, you're looking at a 60 to 65 pound weight loss with the gastric sleeve. And this is actually the most commonly performed bariatric surgery now in the United States, and definitely a Christiana as well. This is a great video. I hope it will play for us. So it just shows how we do this. So all of our surgeries are done what's quote minimally invasive. So laparoscopically or with the robot. This is kind of a funny way of describing how the instruments go in, but you can see small incisions, long instruments to actually get into the stomach. This animation just shows us how this stomach is kind of filling with food. And then down here by this portion of the small bowel where it kind of changes from that blue to yellow is where the digestion occurs, where the digestive juices start, being produced and going into the small bowel. So you can see after surgery, there we go. That portion of the stomach is removed, stapled off, tubular stomach, kind of slower movement, less food can fit, but you're still having the production of the digestive juices and the food and all the digestive juices meeting at the same location. But again, smaller, less hunger, great weight loss long-term. So a really good option. And then the gastric bypass. So this is, as I described before, we create this pouch of stomach. So whereas the sleeve kind of makes a banana out of the stomach, this surgery makes this pouch about the size of an egg. And we actually reroute the small bowel to bypass digestion. And this creates some malabsorption. So food flows from the stomach pouch into the lower intestines. And this is the combination of that restrictive procedure of the pouch stomach, and then the malabsorption from actually rearrangement of that small bowel. And here we see definitely a little bit more weight loss, 65 to 75% of your excess weight. So if we're talking again about pounds, 65 to 75 pounds if you're 100 pounds overweight. I think the pounds just makes it a little easier to understand. And again, I have a very similar video, small incisions, same thing, laparoscopic or robotic. Kind of depends on the surgeon's preference, how they were trained. They are equivalent, you get the same procedure. So here, they're going to show you how they make this nice little pouch. Generally, you know, again, about the size of an egg, maybe a little bigger, but an egg is a good, you know, imagination. And then we separate the small bowel at a measured distance, and rearrange. So that small bowel gets connected to the stomach up there, and then the other portion gets reconnected kind of further downstream. So here is really important because you can see the blue food coming in, and you see the yellow digestive enzymes kind of traveling on that other portion of bowel. And then they'll meet, and you can't really see it, but they meet further down. And that's where you're seeing that, you know, malabsorption component of the gastric bypass. So the duodenal switch, again, I like to call it like a, you know, sleeve bypass mix. So this is where the stomach is reduced in size like the sleeve. And then you have rearrangement of the small intestine. Initially, it was a 2 anastomosis procedure, meaning 2 new bowel connections, similar to the bypass. But a lot of people are doing a single connection now, where they connect the duodenum to the small bowel. Again, at a measured distance. This is a very, very precise procedure. There are different lengths for the bypass, depending on the surgeon. But for the duodenal switch, it's a very, very precise measurements to make sure that we don't have too much malabsorption, because for the beginning portion of performing this procedure, there were definitely increased vitamin deficiencies, malnutrition that people were suffering from, because we didn't really understand exactly how much small bowel was capable of being bypassed. So as we learn that, unfortunately or fortunately through trial and error, this procedure has become safer and safer, and the single anastomosis procedure is great, and it's another good option. And again, here, similar to the bypass, you know, 65 to 80% of excess weight loss. And I think, you know, going back to that slide before, which I'll talk about again, a little bit of a tighter window of how much you kind of lose or don't lose. So I can't say that, you know, there's no risks associated with surgery. There are always risks with surgery. Some of these I'll go through with a little bit more detail on later slides, so I'll kind of go quickly through them now. So the marginal ulcer I'll talk about, but this is associated with the gastric bypass. An internal hernia is when the bowel can sort of twist on itself, and that's associated with the bypass and with the duodenal switch. Leak can occur after surgery. You can see that we create new connections. The sleeve has a long staple line. There's a possibility of those breaking down or having a problem and a leak occurring. Blood clot is probably the most common issue after bariatric surgery. And this is because of surgery in general can potentiate blood clots. Being not as active as you were before does that as well. And then actually being overweight is a reason that people get blood clots. So when in our program at Christiana, we send people with a certain BMI home on blood thinning medication to help with preventing those blood clots after surgery. A stenosis or a stricture, which is a tightening. So those can occur at any of the new connections we made, or in the sleeve, kind of along that staple line. Dumping syndrome, which I'll talk a little bit more about later. And then vitamin deficiency, as we said, there is a malabsorptive component. So we want patients to be on a multivitamin long-term. There are actually special multivitamins specifically for bariatric patients. So very important as one of the things to look out for after surgery, vitamin deficiencies. And patients follow with us at least yearly, either with us in our office or with their primary care physician, to make sure that they're getting those nutrient labs and getting those checked so that we don't fall behind. So a marginal ulcer, it's an ulcer that can occur between the connection of the stomach and the small bowel in the gastric bypass. And it generally occurs because of acid exposure to the small bowel, which doesn't normally get acid exposure because it's much further downstream. Can be seen in up to 16% of patients. I would say that in my experience, not as high as that, but the literature quotes anywhere from like 1% to 16%, so up to 16%. It is associated with things like smoking. So our patients have to quit smoking before surgery. We actually require a urine smoking, like a urine nicotine test, to make sure that our patients have quit smoking, because it's such an important thing to have done before getting these surgeries. We want everyone to be set up to succeed, and developing an ulcer like this can actually be detrimental in the long term. Other reasons you might develop a marginal ulcer are NSAIDs. So those are medications like ibuprofen, Aleve, naproxen, Advil, steroids. So if somebody has, rheumatoid arthritis, is on chronic steroids, we may say, hey, why don't we consider the sleeve over the bypass, because although we don't really want our patients with sleeves taking, those NSAIDs or those steroids, it's safer than if they had a bypass, and puts them at less risk. And then there is some information out there that a pouch size that's too large can actually promote this as well. And that's probably because there's a larger portion of the stomach, and a larger portion of the stomach means more acid producing cells, and more acid producing cells mean more likelihood to form an ulcer. So people usually come in, they have upper belly pain, sometimes they have nausea. Sometimes people even complain like, I can't even really eat much anymore. Like I get nauseous when I eat, difficulty swallowing, because these ulcers can be so bad that they actually cause a stenosis or stricture at the connection site. And the way we diagnose these, a lot of the times it's clinical, because the patient has a bypass. They actually tell you, oh, I started smoking again, and we give them medications, an antacid and a medication that kind of coats the stomach and the area to help with promote healing, and then help them with getting back on track and quitting smoking, or stopping the NSAIDs and switching to Tylenol for pain controls. And people recover well. Scary instances of this happening are where people can actually bleed. And you can have so much bleeding that you need surgery, or you need an upper endoscopy where they stop the bleeding by putting a scope that goes in your mouth, in your esophagus, into your stomach, and looks around, and the gastroenterology doctors are able to kind of help us with stopping the bleeding that way. And then the other thing that ulcers do is perforate. And perforate means get a hole. So this ulcer can actually erode all the way through the stomach lining, to actually create a small hole so that fluid and stomach juices are leaking out into your abdominal cavity. And that generally requires a surgical intervention to kind of patch that hole and wash out the belly. We're lucky in that we've all been trained in this minimally invasive approach. So a lot of the time we can still do this with little incisions, and we don't have to make a big incision. But if somebody's really sick, then they may end up getting that bigger incision on their belly, so that we can really take a look and make sure that we're doing the right thing for them. And then internal hernia and leak. So an internal hernia is where the bowel kind of twists upon itself. And the reason this happens is because we actually kind of make what's called a hernia, or an opening, an open space for things to travel through during the surgery. We now close those areas that we create, but we didn't always, because we didn't, that's what would happen. And so I think seeing a lot less internal hernias because we are taking the time to close those defects. But that doesn't mean that they can't open up over time. The tissue we sew together is kind of fatty tissue to fatty tissue. So if you can imagine, you'll lose the fatty tissue on the outside, you can lose some of that fatty tissue on the inside, allowing for that to open up. Occurs in up to 10% of patients. Again, that is like the high quote in the literature. Low quotes are closer to like 0.7%. As I said, it's less likely now because of all these surgical changes we've made. And you may need surgery in the future if it's discovered. Generally, people come in, upper belly pain, nausea, vomiting. They're not passing gas. They're not having bowel movements because it causes an obstruction of the small bowel, or a kink on that small bowel that doesn't allow food and digestive juices to pass. So a lot of times these people will need surgery. Again, generally small incisions. Sometimes we have to do big incisions again. So very important for our patients to be aware of long-term, so that when they have those symptoms, they come in and see us right away, generally in the emergency department. And then a leak. So this can occur in up to 7% of the patients. Usually we see these things early. So less than about 72 hours post-operatively. And I would say most of the time, even sooner than that. But this is sometimes fixed with endoscopy, meaning, again, that scope that goes in your mouth, down your esophagus, into your stomach. And you can put almost like a long tube kind of across the leak. If it's a later leak, or the patient has gone home and it's been a few days, that may mean that they need both an endoscopic approach and a surgery. So another very important aspect that patients should be aware of, and that we really like to tell people about so that they know kind of signs and symptoms to come back and see us. Dumping syndrome. This occurs in about 13% of patients. Generally in the gastric bypass, not so much in the sleeve, although there are some patients who talk about having this in the sleeve. And it happens after you eat carbohydrate-rich foods and sometimes really fatty foods. And it's related to how sugar kind of travels in the jejunum, which is a portion of the small bowel, and causes a fluid shift. And you get this sympathetic system response that includes diarrhea, nausea, vomiting, a racing heart and palpitations, very uncomfortable, very unnerving. It can occur within 20 minutes. And then sometimes there's a late dumping that occurs about up to 4 hours after ingestion of these foods. I put this little bullet here, protective. It's kind of telling you, hey, stay away from this food. It's not the kind you want to eat. Because we want our patients to really focus on high protein, low carbohydrate diet, because that is ultimately the best way to lose weight and keep weight off long term. So I try to, relax patients a little bit about it by saying it's just your body telling you that this isn't what you should be eating, and potentially it's a good thing for you, so you're not going back for that, second bite of the ice cream, for whatever that's worth. So our program actually has a really extensive preoperative preparation. And this is because we really believe that bariatric surgery is a tool. It is not an easy fix. It is a process. It still requires long-term commitment. We're talking lifestyle changes, diet changes. I mean, quitting smoking, no longer taking ibuprofen. I mean, these are things that people, do daily. So the first step is being interested and wanting to know about surgery. So we have a special seminar, which actually talks a lot about the stuff that I already went over here, but just in a little bit more detail and allows people to ask questions. Once you do that, you get to see us in the office and you can pick your surgeon. There are 5 of us. It's a lengthy preoperative workup. And this is sometimes dictated by insurance, but even if your insurance doesn't have any requirements, our program requires certain things. So everyone visits with a medical doctor that's associated with Christiana, and they get all of your labs, they check your heart, send you for a sleep study if they're concerned about some sort of sleep apnea, and really make sure that a patient is medically optimized to get the surgery, because every surgery comes with risks and we want our patients at their best before we do that. There's a meeting with a dietitian and a psychologist, and they review, healthy habits. What have you tried in the past? What are your barriers to continuing on a diet? How can we best serve you to make sure that you're successful long-term? There are life skills classes. So these go over protein, where to get protein, how to get protein, vitamins, what vitamins are good, which ones cover everything, which vitamins you should take if for supplementation, if you're taking, one vitamin that doesn't have all the same nutritional value, exercise. So really important stuff about behavior changing and getting ready going into surgery. We all perform an endoscopy on our patients preoperatively, and this makes sure that, we want to know their anatomy. We want to make sure there's nothing that we're missing before we do surgery that may prevent us from doing surgery or change our decision for doing one surgery or the other. Once all of that's done, there's an insurance approval process. And for our program, after this insurance approval process, we do a weight check. And we really want to see that people are at a stable weight or lower weight before going into surgery. I'm not talking like, let's say somebody gained 1, 2, 3 pounds. Okay. But we want to see that you're really working hard to stay committed to an exercise and to a diet program, because you are still going to need that after surgery. And then patients have a preoperative appointment. There is a very important 2-week preoperative diet that comes after that, and then surgery. So the preoperative diet is actually high protein, low carbs, mostly like protein shake based, to help with shrinking the liver before surgery. So if you saw in those videos, there's the stomach, and then it goes into what's called the duodenum, or that first part of the small bowel. Well, the liver actually kind of sits right on top of that. So for our surgery, we have to lift that liver out of the way. And if you can imagine, a big fatty liver is very difficult to move out of the way, not only because of its size, but because actually fat can infiltrate into the liver cells, and it makes it softer. So soft is not good because it can mean that we can damage the liver while we're trying to move it out of the way. So it's a really important step before surgery. And it also helps patients out because they generally lose a little bit of weight before surgery, and they feel really good going into surgery. Like, oh, I did the diet and I lost, 5 pounds, or I did the diet and I lost 10 pounds. So already seeing results before we've even made an incision. So it's very exciting. And I'd like to address a little bit about, post-operative expectations. So I'll go back to weight loss. Again, we talked about this. Bypass, you're going to see a little bit more weight loss. Sleeve, maybe a little bit less. And then the duodenal switch, probably a little bit more overall. At Christiana, most of us are doing the sleeve or the bypass. And I would say the majority of patients are getting the gastric sleeve. It is a little bit less risk than both of those other procedures as well. especially long-term. We talked about the kind of like big, scary risks, the marginal ulcer and the internal hernia. And both of those are not going to occur in somebody who's had a sleeve. So kind of depending on other issues with, your health, we generally go with the sleeve as that first option. There are some things that would lead us to choose a bypass. People that have a lot of like heartburn or reflux, the sleeve can actually make that worse. And then people with diabetes that's generally controlled by insulin, sometimes we try to we try to recommend towards the gastric bypass because there's a lot of long-term data that the bypass really helps with resolution and remission of diabetes. So comorbidity reduction after surgery. So this is all of those other medical problems that people have that get better after surgery. And I think that this should be the take home. This is like the most exciting part. This isn't just about weight loss. This is about all of the other issues that may come with being obese or overweight. 92% of people see resolution of their diabetes or improvement. That means if they were on insulin before, maybe they're not on insulin, or maybe their diabetes is, pre-diabetes now because they're off all medications and their numbers are looking so good. High blood pressure, 75% of people have resolved or improved blood pressure after surgery. Again, this could mean a reduction in medications. This could mean that you're off medications. I mean, this stuff makes a really huge difference long-term. Sleep apnea, 96%. So if you know anybody with sleep apnea, I'm sure you've heard about their CPAP machine and how uncomfortable it is. They don't want to wear it. They end up taking it off halfway through the night because it's uncomfortable and you can't sleep well. Well, with bariatric surgery, there's a really high probability that you won't need that. And then hyperlipidemia, which is also known as high cholesterol. Again, about 76% of people have resolution or improvement. So very exciting. And I showed you that slide in the beginning about all of the organ systems that are affected by being morbidly obese. And this slide here shows you that reduction in all of those organ systems issues. So things like migraines are resolved, fatty liver is resolved, and actually, non-alcoholic fatty liver disease can lead to things like cirrhosis. So it's really great that we're able to reduce that inflammation and reduce that in patients that come in with that. Reflux. So if you do have reflux, and we know you have reflux, and we go for the bypass, many people don't need medications once they've had the surgery. Asthma is resolved, about 82% improved. So it's really wonderful to see how patients improve their overall health after the surgery. And then most exciting is that mortality decreases significantly within 5 years after having had this surgery. And that's because of all of those other comorbidities that affect people and can lead to early death. So this paper just kind of, again, goes over that quality of life after surgery. I see patients all the time. We have, groups that we have joined. We have special private Facebook groups so people can, stay private, but share all of their successes. And this shows that the weight you lose, the more weight you lose, the higher your quality of life score. And it doesn't differ much between the sleeve or the bypass as far as quality of life. So really exciting to see that people, are doing better, feeling better after getting the surgery. And yet another article that just confirms this. I think this one I found more interesting because it really showed that there wasn't a difference between sleeve gastrectomy or bypass in terms of quality of life, questionnaires long term. Both groups felt so much better after surgery than they did before surgery. And I think that's kind of the most exciting thing for me as a bariatric surgeon, to see how well people do and to be able to be there on this journey with them. So with that, I would like to share the most important perspective of all of this, and hear from Shellee about her experience.
Thanks, Dr. McCarthy. As Dr. McCarthy said, my name is Shellee. I was a patient, or I am a patient of Dr. Halbert at Christiana. She is amazing. And she is literally, and the Christiana program has literally saved my life. I had surgery 2.5 years ago in September of 2020. I began the process in 2019. I've been thinking about bariatric surgery probably since I was in my 20s. At the time, I was either too afraid of what somebody else might think, or my insurance didn't cover it. I was always overweight. I don't think there was a time other than maybe 5 minutes when I was 12 that I was at a healthy weight. Obesity runs in my family, not in my immediate family, but I have many relatives that fight weight. So there's definitely that genetic component that Dr. McCarthy talked about in my family. My immediate family, my dad was always at a healthy weight. My brother, my mom battled her weight, but she always kept it under control. She worked very, very, very hard. And, she's always been relatively thin. And I was the obese one. And my weight would bounce up and down. I started, my earliest diet that I remember was I went to Weight Watchers when I was about 11 years old with my mom. And they told me, I'm 5'5". I've been 5'5" since I was 12. And they told me that I should weigh 98 pounds. And it actually put me on a path of really bad. I actually went to almost anorexic. As a result, I never got down to that. And then I just went completely off the rails. I gained weight so rapidly that I was changing sizes and becoming less active every day, every week, every month. When I went away to college, it got even worse. So that being said, as I went through my 20s and my 30s and my 40s, my weight just kept climbing, and I would go on diets and I would exercise. I was always reasonably active as I could be at the weight I was. But I was never consistent, and I never could stick with it. I could lose about 40 pounds. I did every diet there is. I did MetaFast. I did intermittent fasting. I did keto. I've done it all. Weight Watchers dozens of times. And it just didn't stick for me. So I had a cousin that took the step and had the surgery, had gastric sleeve surgery in 2017 with Dr. Halbert. And she had confided to me because she knew we both battled our weight. She had a lot of really serious health issues, and I was developing them. We have osteoarthritis in our family. I have really bad knees. It was becoming difficult for me to do anything that I loved. I loved to travel. I was having trouble getting on planes. I couldn't fit in the seats. I couldn't button the seatbelts. And my cousin had some very, very serious medical problems that were getting worse with her weight as it climbed. So she had gastric sleeve surgery. She was really successful. She spoke so highly of Christiana's program and Dr. Halbert. And after about a year, I was like, can you give me her number? And I started thinking about it, and I chickened out in 2018. And then in 2019, I've been getting shots in my knees because I just had the arthritis was so bad, and it wasn't helping anymore. And I asked the orthopedic doctor, how do I go about getting my knee replaced? And he very quietly and very politely said, well, we'd have to get your BMI down pretty significantly, which, that's always painful to hear, but I'm not naive to the fact that I was overweight. And I said to him, well, what would my BMI have to be? And he very quietly told me, and that was it. He didn't he wasn't rude about it. He was very just kind of quiet about it. And in my head, I was like, that's a lot, because I know my BMI is nowhere near that. And I went home and went on the BMI calculator, like Dr. McCarthy said, and it was well over 100 pounds that I knew I had to lose. And I also knew that in a year I wouldn't be able to walk, as my cousin had gone through. And I didn't want to go down that path. And what she always told me was that she wished she had done it. She did it in her 60s. And she wished that she had done it when she was my age. And at that time I was 48 years old, 49. So I made the appointment with Dr. Halbert. I did the seminar that Christiana puts on. I made the appointment. I called in August. The first seminar that they had available was in November. Made the appointment and kind of went on with my life and just, you know, went on my daily life being obese and being in a lot of pain all the time. I went on a road trip in September of 2019 and I could barely do anything. I was having difficulty walking. I was miserable. And I just was so looking forward to that seminar so that I had hope. And at that same time, I came home and my dad was diagnosed with a very aggressive form of cancer and out of nowhere. And I am my parents' primary caretakers. They were both up to that point very healthy, but I knew that I was going to have to care for him through this treatment. And so I went to the seminar actually on the day that he started treatment. And I told no one but my cousin and a dear friend that had also had VSU years before. They were the only two people that knew. I never told my parents. I never told any of my friends. I just went to the seminar and I signed up for an appointment with Dr. Halbert that night. I went to see her on January 6th, 2020. And immediately just, I felt like I was at home. She made me feel so positive. She made me feel like there was nothing to worry about. They were going to take care of me. And I was going to come out of this just, you know, a healthy, more active person. And that, you know, that Christiana was going to take care of me and Dr. Halbert was going to take care of me and get me through this. So I left with my big white binder that they give you with all of this information. It's a little daunting, the first appointment, I'm not going to lie, but and you meet with the coordinators of the weight management department and they set you up for all of these appointments. Sleep apnea test, which I was not happy about. They told me I had sleep apnea and had to wear a CPAP, which I was not happy about. But I did it because you have to wear it to get qualified for surgery. So, and at that point, I would do anything to get qualified for surgery. So I had the EGD. I went to all the classes and COVID hit. So all of my in-person classes that I was going to then became virtual, which became very difficult. But I really listened. I'm a very good student. I'm kind of a nerd. I take a lot of notes and I do a lot of research, and I read more about bariatric surgery and what causes obesity and the ghrelin hormone. And just finally, I felt like I was validated that I wasn't lazy and that, you know, I had tried everything. And there were all of these hormonal and mental things that when you're obese occur with you that don't happen with other people. And it was finally like, okay, I'm not crazy. I thought I was crazy all these years. That, you know, why I couldn't stop eating and why I always wanted junk food and carbs and all this stuff. So the Christiana program is just absolutely incredible with education. And my surgery was delayed because of that darn COVID thing for about 3 months. And, you know, I had a big pity party for myself. And I was like, and I started losing weight during the process because I was like, well, you know, I might as well start making changes now, because I figured after surgery, if I didn't, it was just going to be the worst experience. So after I found out my surgery was going to be delayed because Christiana closed basically to surgery, to optional surgery, I gained a couple pounds back, and then I basically put my big girl panties back on and just was determined that I was going to make all the changes I needed to ahead of surgery. So I quit drinking. I like to drink. I'm not going to lie. My friends and I, it was pretty much what we did for fun. And I quit by July of that summer, cold turkey. And I told all my friends and my family about the surgery by now. So like I had a really good support system. I started exercising regularly as much as I could. It was agonizing with my knees and just the weight on them. But I, you know, I had a big pity party for myself, and I was like, and I gave, I'd started losing weight during the process because I was like, well, you know, I might as well start making changes now, because I figured after surgery, if I didn't, it was just going to be the worst experience. So I tried to do something every day, whether it was lifting weights or just going for a walk. And at that point, a half a mile seemed like a marathon. But I did it, and I was sweaty and in pain and hating life, basically. But I did it. And by July, I got approved for surgery. It was the happiest day of my life. I was on vacation with my family at the beach. We were kind of on lockdown beach vacation with COVID. And it was like the best day ever. It was the best phone call I've ever gotten. I was so excited. I went in for my weigh-in. I got my dreaded pre-op diet food. I call it food as a very loose interpretation. I got a bunch of powders and some shakes, and ta-da. And I started my pre-op diet on Labor Day of 2020, and I had surgery on September 21st, 2020. I was beyond ready. I lost 25 pounds before the pre-op. So at my weigh-in, I was 25 pounds less than when I had first seen Dr. Halbert. I felt pretty darn good about myself. But I still couldn't see like how in a year I was going to weigh 100 pounds less. Like that just seemed insurmountable to me. But I was like, well, we'll see what happens. You know, maybe I will, maybe I won't. So I went to surgery. I was the first patient of the day. Dr. Halbert came in with her big smile and just, oh, we're going to take care of you. This is going to be no big deal. You're going to feel great afterwards. And I did. I know a lot of people have trouble with anesthesia, or, they don't feel great after surgery. I felt great. like I just felt I had done some sit-ups. My stomach was a little sore, but honestly, the nurses checked me in, and I was like, can I start walking to get rid of this gas in my belly? And they were like, yeah, do you feel up to it? And I was like, yeah. And I literally just walked for hours around the floor. They would laugh at me, and the nurses are like, there she goes again. And to the point where later that evening, when the resident, Dr. Halbert's resident, came to check on me at like 5 o'clock, he couldn't find me because I was out meandering somewhere around the floor. And he found me. He goes, are you Shellee? And I said, yeah, I'm Shellee. And he goes, you look really good for having surgery this morning. I'm like, well, I mean, I don't know about that, but thanks. He goes, you look like you could go home. And I was like, I can get a ride in 20 minutes, doctor. Like, let's go. I want to go home. He wouldn't let me go home. He said Dr. Halbert would kill him. So I didn't want to ruin his medical career. So I stayed. But he did put me on full liquids. Most people don't go until day 2, right before you leave. I started 5:30 the day of surgery. And the only thing that I had trouble with was water. During life skills, they tell you that some people post-op can't drink regular water. And I thought that was the dumbest thing I'd ever heard of. I drank water all the time pre-op. So to me, I was like, oh, all this water I have to drink, no big deal. And I thought anybody who says that like water makes them nauseous, it just means that they drank sugary stuff beforehand, and it's just that. And I'm doing my little shot glasses, and they give you Crystal Light, some cranberry juice, and then water. And I do my one shot every so often that they tell you to do it. And I get to the water, and I would feel just a tiny, tiny bit nauseous. Not like I was going to get sick, but just different. And I thought, no, it can't be. Went back and did them again. And I was like, oh, it is. Okay. Well, no more water for me. So I just drank the rest of it. It was totally fine. No problem. Slept, got up the next morning, and I was the first patient discharged. I was home by 11 o'clock the day after surgery. I felt fantastic, honestly. Again, it just felt like I had done some sit-ups. I did all the diet. I did the liquid diet. I drank all the shakes. I made all my protein goals on the first day. I have had 0 food intolerances. Unfortunately, I can eat sugar now. I did not do that for the first year. I don't dump. I don't have reflux. Nothing really bothers me, honestly, other than the water thing. So I just put Crystal Light or Mayo in my water, and it's fine. It doesn't bother me. I drink tons of water. I was off my blood pressure medicine in 5 days. My cholesterol was down to healthy levels at my first blood work post-op. I never wore the CPAP again. Don't tell anybody, but I never wore it again after surgery because I hated it so much, and I didn't feel like I needed it, but I did it to qualify. A lot of people need it, so wear it if you have to, if they tell you have to. It is for your safety. I didn't feel like I needed it, so I never wore it again. I lost weight fairly steadily. I hit the stalls just like everybody does at each meal progression. I followed all the rules that Christianity gives you. They prepare you very, very well if you pay attention to the information they give you. It is extremely thorough and detailed. And I had cleared my entire house of everything that I could not eat post-op. I gave away all my food. I gave away every bit of pasta, any kind of soda that I really didn't drink anyway, but anything that I knew that could be tempting post-op, I just gave it away. And it was fine. The scale was my reward. I was able to walk further every day. My clothes were fitting better, obviously. And by my first year appointment, my follow-up with Dr. Hal, with Deb, the nurse practitioner, I lost 150 pounds total, including my pre-op 25. So I lost 125 since surgery, and I lost 150 total. I'm 2.5 years post-op right now. I have had some regain in the last year. Thank you. That's a very nice comment. Thank you. I did have knee replacement surgery last May for my one knee. I need the other one done eventually, but it's fine. I walked 2 miles the day before surgery. I walked 2 miles the morning of my knee replacement. And I did a 5K 8 weeks after a 5K walk, 8 weeks after my knee replacement. So I now walk 2.5 to 3 miles every single day. I do competitive 5K walks. Right now I'm doing one a month at least, but just as a goal for this year. I have had some regain this year that I've been struggling with, but I immediately followed all the advice that Christiana gives you. And I reached out to the team as soon as I felt like I was spiraling. And it mainly happened after I had my knee replacement. I started, because I wasn't active immediately. And while I was following the diet, I saw the scale just creeping up, and it just scared me to death. And Christiana jumped right in. The whole team did. I met with nutrition. I met with Deb, our nurse practitioner. They all gave me advice. I've subsequently started seeing the psychologist, Megan Lavery. She's amazing. And she knows all about this process and what we go through, and what obesity is about, and what struggles we have with our body image and everything like that. But I have absolutely no regrets, other than I didn't do it earlier in life. But I don't know that I would have been as successful as I have been, honestly. I think that when I did it, I was ready. And I've done more in the last 2 years, like adventure-wise, than I have in my entire life. I've gone on a hot air balloon ride. I've gone zip lining. I've done these 5Ks that were like, there was no chance I could have ever done that before in my life. I'm able to care for my parents. My dad did survive his cancer. He had a very rare and aggressive cancer. He's now doing great. They're 80 and 78, and probably the most active 78-year-old and 80-year-old you'll ever want to meet. But I still, they still need help. They're 80 years old. So I'm able to do everything around their house that they can't do any longer. I'm able to do everything around my house that I can't do, that I couldn't do before. So life is 1,000 times better. And I can never thank Christiana enough. It is the best program for bariatrics that I've ever come across. I know a lot of people that have had surgery, and long-term, they were not successful because they didn't have the support or the education that we get. The Facebook group that Christiana has for bariatrics is incredible. I've made amazing friends. It's a way to help you stay accountable long-term. You can help new patients get through what you've already gone through, and just, lend your advice. And we cheer each other on when we have NSVs, non-scale victories. So, just those little things like fastening a seatbelt on a plane. When you're obese and you have to ask for that seatbelt extender, it's the most embarrassing thing ever. Or when you can't put the armrest down and you're sitting next to somebody you don't know and you feel like you're impeding on their seat. The first plane ride I took was a year after surgery, and I almost cried when I buckled that seatbelt, because I hadn't been able to buckle an airplane seatbelt in probably 15 years. And it was embarrassing. It was just always torture to get down the aisle and everything like that. And now I fit down that aisle with no trouble. I can shop anywhere I want, which is kind of nice. I'll never be skinny, and I don't really care. I'm healthy. So Christiana's the best. If anybody out there is considering having surgery, go and do it. It's the best gift you will ever give yourself. So that's my story.
Shellee, that was amazing. Actually, there's a question for you. Can I ask you? All right. Absolutely. So there's a question in the chat that says, being that eating is somewhat dictated by quote unquote feeling hungry, whatever that is, do you still struggle with feeling like you want to eat?
So that's a really, really great question. Early on, I had zero, like post-op, I literally was never hungry for probably the first 18 months. I couldn't care less. I ate because it was my job. I knew I had to eat for my health, and I had to meet my goals, and I had to hit my 80 grams of protein and my water every day. So I did not, that ghrelin hormone was gone. And it was like that switch in my head that always told me I was hungry was gone. It has subsequently come back. And that's what I was struggling with. And that's when I started seeing the regain. And that's why I went back to the team. They've helped me with some, with some medication, and then the therapy that I've been going through is really helping. It's not easy. It's a choice every single day, but some days I make better choices than others these days, but overall I'm, staying as in control as I feel like I can. So.
Fabulous. We have more questions in the chat, but I want to make sure Dr. McCarthy can finish what she's talking about too.
Sorry if I talk too long.
No, you're fine.
No, actually, Shellee was my wrap up. So she stole the show and did exactly what I wanted her to do.
She did. There are lots of questions in the chat. Well, there were lots of questions in the chat before Shellee started talking, but now there are even more. So I'm going to maybe go back and forth.
Okay. Thanks, Marika. I know,
yes,
Marika.
Lots of
Marika's
congratulations
one of
in
my,
the chat.
yeah, Marika's in our support group. She's great. So
perfect. So for Dr. McCarthy, are these surgeries used for weight loss only or for other medical conditions?
So that is a really good question. So sometimes if people have bad enough reflux, we will do a gastric bypass for the reflux, maybe more than weight loss necessarily. But that's really if a patient's BMI is still approaching 35 or at 35. But I would say that this surgery isn't just for weight loss. I mean, that is a big component of it. But when I think about this surgery, I think about this as like metabolic surgery. So I think about it for people who have the high blood pressure, diabetes, sleep apnea, and the other issues that are also affecting, their health. Of course, weight loss is a component. And I think, the reason we do it for people who may not have those comorbidities yet is because we know what happens when people continue to gain weight or continue to stay at a heavy weight, and that they are more likely to have those medical issues. So it's weight loss surgery, but I really think it's more about the health aspect and being healthier than it is about weight loss. But as for like, do we specifically do it for, if somebody has diabetes and has a BMI less than 35, I actually did have a patient in fellowship who was diabetic on like insulin, so much insulin that she could like barely keep up. And she was like, I'm done. And her BMI was in the like low 30 range. And she actually ended up just saying like, I'm going to pay out of pocket for surgery if insurance isn't going to cover it, because I know that this surgery helps with diabetes. And she's on like much less medication now than she was before surgery.
Is there like a minimum or maximum age limit or weight limit with these surgeries?
So age limit at Christiana, we only do, 18 or above. There are pediatric programs, and there is a program at Nemours for pediatric patients. The workup for that is a little bit different, a little bit longer, because obviously it involves like the whole family system, because as we went back to in the beginning, obesity isn't just related to genetics or just to overeating or just to environment. It's all kind of, together. So young kids, teenagers can get surgery. Again, in fellowship, we had a couple patients who were like 16, 17 who got the sleeve gastrectomy. And I would think in most patients, we'd probably say the sleeve is a better option for them than the bypass, just because long-term wise, what, the risks we look at. It's definitely something we're doing. It's proven to be safe. And I think that we'll be seeing more of it, because if we can fix obesity early, we can fix all of the medical problems that are associated with it as well.